Good afternoon, everyone. I'm Xuan, GovInsider's Deputy Editor, and welcome to Connecting the Dots for Integrated Healthcare. I'm very excited for today's session, where we'll be exploring some of the cutting-edge ways that data has enabled personalized and integrated care. A very big thank you to our partners at AWS for making this session possible. Let me introduce our star-studded lineup for today. First up, we have Dr. Simon Lee, who is the Chief Operating Officer and Chief Clinical Informatics Officer at National Healthcare Group Polyclinics. We have with us Clinical Assistant Professor Luke Loh, who is the Chief Medical Informatics Officer at SingHealth. We also have Chris Ng, who is the Group Chief Data Governance and Protection Officer at National University Health System. Next up, Dr. Jamie Mervyn Lim, who is the Chief Operating Officer at Tan Tock Seng Hospital. Joining us as well is Andy Ta, Director of Data Analytics and AI at IHiS. And last but certainly not least, we have Dr. Andrew Jones, who is the Head of Clinical Innovation at AWS Worldwide Public Sector. Starting us off this afternoon is Dr. Simon Lee from the National Healthcare Group Polyclinics. He will be sharing how Singapore's primary care is using data and tech to provide personalized and seamless services. Dr. Simon, take it away, please.
Very good afternoon to everyone. For my segment, I will talk about how we use data to enable personalized and integrated care and how we leverage technology to provide seamless services throughout the patient care journey. This diagram is a simplified data life cycle. There are many versions with four main components. Data collection. This requires consent. In our case, this is implied by virtue of the patient coming to our facilities for consultation and treatment, and the patient charter that is displayed prominently makes it clear to the patients how the collected data will be used and that it may be shared among the cluster institutions for the purpose of delivering care. Data usage. We use data to drive care and plan services based on patient demographics, utilization patterns, and so on. Data is needed for population health management. It enables us to identify a patient's care gaps and help prompt health maintenance tasks. Data aggregation and visualization can help provide new insights into how we practice. Data storage and disposal. Most of us are familiar with data warehouses, which hold selected structured data that has been processed for specific use cases, which can be readily accessed by many operational users on the ground, but for which making changes can be costly and difficult. Data lakes, on the other hand, accept all data, both structured and unstructured, without need for predetermined use cases, which can be quickly accessed by highly trained professionals. NHG is enhancing its data analysis infrastructure, which includes a data lake approach. Data disclosure and transfer and sharing. Data that sits unused in a database is of no value. It has to be made available to those who are authorized to access it, whether for their own health, in the case of patients and their caregivers, or to enable better care for patients in the case of the healthcare providers. I will elaborate subsequently on some of the platforms through which we endeavor to do this. I will use this slide to illustrate the way the information needs to flow, starting with reaching the most important person, the patient and family, flowing vertically between primary and tertiary care, and horizontally between primary care and community partners. I will next touch on the various IT enablers before returning to this slide later. I trust most of the citizens here are familiar with Health Hub. It is a one-stop portal and mobile app for Singaporeans to access a wide range of health content, rewards, and e-services. It is designed to empower Singaporeans to take greater ownership of their health and wellness through the online access of personalized health records, better health literacy, and adoption of healthy lifestyle practices. The contents include health education materials, patient medical information, such as medication lists, test results, immunizations, vital signs, such as weight and blood pressure, as well as transactional capabilities such as displaying and booking of appointments and making payments. Beyond the foundational capabilities of Health Hub, each public healthcare cluster is also developing its own app or suite of apps. NHG and NUHS will both be using Epic as our EMR and intend to leverage on its native MyChart capability to provide their patients with a richer set of data and functionality for greater interaction. The National Electronic Health Record receives and consolidates data from various healthcare institutions and national registries into a holistic health record. It includes information such as diagnoses and problem lists, patient medication lists and adverse drug reactions, investigation results and images, past visits and future appointments, discharge summaries and referral letters. In this way, when a patient presents at any healthcare facility that has access to the NEHR, authorized healthcare professionals are able to get an overview of the patient's health status, and this makes care safer, better, and more personalized. Some of this information is also made available to the patient through Health Hub. The benefits include, firstly, the data is securely stored in one place electronically. This enables multidisciplinary healthcare professionals across Singapore to work together to provide better care. Secondly, with a better understanding of the patient's healthcare history, clinicians can make better informed diagnoses and decisions for the best course of treatment. Thirdly, by being able to view the medication that the patient is taking, allergies, and other essential information, clinicians are able to provide appropriate care and avoid unnecessary adverse drug reactions, even when the patient or caregiver is unable to provide this information, such as in an emergency setting. Fourthly, decentralized record also helps patients to move seamlessly across providers, providing greater convenience and minimizing duplication of tests. Unfortunately, the NEHR does not contain clinical documentation such as outpatient consultation notes or inpatient progress notes. While the reader has access to the key structured objective data, he or she may be unable to discern the thought processes or intentions behind a course of action, as well as the upcoming plan for the patient. It also does not record the patient's wishes and expectations or the outcome of a case conference with next of kin. The next generation electronic medical record project involves two of the three public healthcare clusters. As a full EMR, it has a much richer dataset compared to the NEHR. Benefits of this project include sharing of data between the public healthcare institutions of both clusters for better patient care through enabling medication reconciliation, avoiding duplication of tests, and so on. Central to this effort was standardization of data definitions and harmonization of workflows. The shared data enables the clinicians to identify care gaps for each patient and prompts them to perform health maintenance tasks. It also provides data that can be used to achieve value-driven outcomes and even has metrics on how users cope with the system to drive post-go life optimization. Coming back to this slide, the One Care Plan is a cross-institutional initiative for all patients to have a single shared patient care plan visible to all care providers and patients for seamless care transition and care coordination across all patient care settings. It is a dynamic care plan leveraging on IT platforms to provide the most up-to-date information to patients and their care providers. This patient-centric One Care Plan will reflect the patient's clinical, social, behavioral, and health promotion needs, as well as the patient's values and choices. We will also have a detailed shared plan of care for the more complex patients that require care across primary and tertiary institutions. Next, I would like to touch on some of the ways that the National Healthcare Group Polyclinics has endeavored to use technology to improve care and provide seamless services throughout a patient's care journey. I will start by describing our telehealth journey. We actually started back in 2013 with our telecare service where care managers, who are nurses, provided teleconsultations for stable patients with well-controlled chronic diseases. In 2016, we commenced a telecollaboration with the National Skin Centre, in which our patients can get a dermatologist's opinion without needing to make a physical visit to NSC. As well as another telecollaboration with the cardiology department in Tock Seng for patients with abnormal electrocardiograms. We also started our telewound program to enable our patients to manage and dress their wounds themselves at home. I will mention more about the PTAC program later. Acceptance and adoption of telehealth by our patients really took off in a big way with the advent of the COVID-19 pandemic. With patients preferring to stay at home instead of making physical visits to our clinics, our doctors started doing teleconsultations, initially over the phone, then subsequently as video consultations. Our care managers continued to provide nursing advice remotely. In addition, we started to provide allied health services through telehealth, psychology, dietetics, and physiotherapy. We also leveraged video conferencing to observe our patients taking their anti-tuberculosis medication remotely. Patient satisfaction and empowerment was high, with the vast majority indicating that they would use the service again and that they had a good understanding of what they had to do to manage their health. We leveraged technology to facilitate the conduct of teleconsultations. Suitable patients were identified through the use of predictive analytics. Prospective patients were taught how to use a Zoom platform. The IT system was enhanced to allow more mass actualization of the virtual appointments. A whole medication delivery portal to allow patients to confirm their addresses and select the delivery time is pending security clearance as it is internet facing. NHEP worked with the Ministry of Health's Office for Healthcare Transformation to pilot the PTech project at Ang Mo Kio Polyclinic in 2019. The pilot focused on hypertension. Patients used Bluetooth-enabled devices, which are simple to use, to measure blood pressure weekly at home and automatically upload readings which could be viewed by the care team in the polyclinic. A backend analytics system designed with clinical protocols created a task list for the care team comprising patients with increased monthly average readings and also flagged up patients with very high or very low readings. The care team then provided support through teleconsultation and titration of medication when required. A rule-based SMS chatbot provided reminders if readings were not uploaded and provided patients with guidance for very high and very low readings, thus giving patients a timely response and encouragement before teleconsultation with the care team. The pilot demonstrated good results. There was improved blood pressure control, especially for the group with suboptimal or uncontrolled blood pressure. The number of physical visits was reduced for well-controlled patients. It was found to be very cost-effective, with the IHiS being well below WHO's very cost-effective threshold. The weekly self-monitoring by patients increased their self-awareness, empowered them to better self-manage with good patient satisfaction, and accelerated the shift towards home management. PTech augments and enhances current care. It is now slated to be scaled up and spread across all the polyclinics. The next step will be expansion into management of DM. Briefly, this slide shows some of the things we have done over the years to move from a walk-in system to a full appointment system to make waiting time more predictable and iteratively improve our kiosk to provide more functions. Fast forwarding to the present, we continue to add more functions to the kiosk, but are also increasingly moving self-help functions online, such as patients updating their own particulars or answering screening questions prior to entry during the pandemic. Thank you.
Thank you, Dr. Simon, for sharing more on Singapore's next generation e-medical record and telehealth initiatives. Next, we have Luke from SingHealth, and he'll be sharing some of SingHealth's emerging innovations in using data for decision-making. Luke, over to you.
Thank you so much, Annabelle. Yeah, so my name is Luke, and a very warm good afternoon to you. Please allow me to tell you more about data-driven, personalized, and seamless health services in a digital age, especially coming from SingHealth. So my colleague Simon has briefly talked about what we have now currently, and I believe that it starts with each and every one of us to take upon our personal health efforts to bring about behavioral change. On the left, right, for those who are healthy residents, we have various initiatives from Health Promotion Board, SingHealth, and IHiS, right? National Steps Challenge with fitness trackers, healthy eating, Lumi Health, right? All these of which you are very familiar with. And on the right, for patients with chronic diseases, the PTech program, which Simon has spoke about earlier as well. But beyond that, we also see other examples of emerging innovations in artificial intelligence, AI. Like for example, how AI is being used in diabetic retinal photos in a joint collaboration between SNEC and SERI. And on your left, you actually see a traditional DRP photo. I remember the days when I had to be trained and certified as a DRP reader, having read hundreds of photos in order to be certified fit to interpret such photos for my patients. Nowadays, with AI pattern recognition, any doctor with such a camera needs only to apply the AI algorithm, and the DRP is interpreted without the doctor having to go for this painful course. And AI has been able to interpret diabetic retinopathy, glaucoma, and age-related macular degeneration. Indeed, the future is bright to even train the AI system to predict which patients will develop eye diseases in the future in very early stages. And even yesterday, I read on the news that AI is now being tested in colonoscopy as well as a second pair of eyes for the scopist. So those were the systems that were patient-fronting. And we do have systems that cater to the healthcare sector and professionals specifically. At a national level, we have NHR that's been in existence since 2011, and Simon has spoken extensively about it. Many of our organizations contribute data to NHR as well, making it an extremely useful system, especially when patients move across clusters. Our interaction with our patients is via apps such as Health Hub or Health Buddy, which shows essential visits, appointments, results to the patients who are more empowered and savvy. And within our own clusters, we have Epic, which is an NG-EMR, and Allscripts as our main clinical systems. Notwithstanding that, even for smaller clinics like the GP clinics who group into primary care networks, PCNs, many of them are on electronic systems such as GP Connect and Clinic Assist. Even nursing homes are on nHelp and InGod. And all these systems contribute a standard data set to NHR to make NHR more robust and rich with essential health information. Because taking the example of SingHealth Community Hospital that I'm familiar with and zooming in, we are comprising of Bright Vision Hospital, Sengkang Community Hospital, and Outram Community Hospital. And being Singapore's only cluster of community hospitals actually allows us the unique opportunity to shape the way we deliver patient-centered care to our patients. Being an intermediate care provider, we receive information patients from acute hospitals and also community partners such as nursing homes for patients who need rehab, subacute, and even palliative care. We work closely with the patients, caregivers, and community partners to prepare them for discharge. And we do discharge many of our patients back to the community, with some supported by community partners such as day rehab centers and home care providers. So we play that key role in bridging care for our partners, and thus information needs to flow between us seamlessly. So we use data to drive our planning and decision making. Through historical referral data, it allows us to optimize bed utilization in SingHealth Community Hospital and give us the opportunity to load balance across our 3 sister CHs. We also use it to decide which services will better cater to our patients, and then determine ramp-up plans for opening of new wards based on demand from the data we get from the patients. If we get increasing referrals for patients with additional needs, high fall risk patients, or patients with dementia, we can then develop programs to cater to such patients. And arising from this, we have also developed joint bundled care programs and value-driven outcome initiatives to optimize overall value for our healthcare system. And now that we have taken stock of the present, how can we envision our future state to be? I believe that whichever forms it comes in, it has to be different from the current system. And I believe that residents and patients will very much prefer their care to be personalized, preventive in nature, they to be more empowered and participative in joint co-creation of care plans, and also to be predictive in nature so as to ensure better outcomes. And indeed, this gives us the opportunity to reinvent care and synergize with MOH's 3 beyonds: beyond hospital to community, beyond healthcare to health, and beyond quality to value. Using digital technologies, we can engage our residents and patients in an integrated and seamless model of primary, secondary, and tertiary care. They can be better managed in healthy eating, healthy living right from the start, and will be better informed and thus empowered every step of the way. And in so doing, we really bridge the gap between health and social care by incorporating health and social determinants in our care delivery and engagement. And our patients will start to see this as a continuous spectrum in this new digital age rather than just being referred from point A to point B. No longer will patients need to physically see a doctor. Even now, but give it another 5 or 10 years, everyone, including many elderlies, will have their own personal mobile devices and wearables, thanks to digital ambassadors, prevalence of devices, and lower cost of ownership for such devices. And to reduce confusion, we should have a single resident-facing app as far as possible to prevent app fatigue and confusion. And it is possible to achieve this app. You can link up multiple back-end application program interfaces, or what I call APIs. We also need to move away from healthcare for the masses into emphasizing more on individualization. There should be less need for big-scale health talks and generic education sessions, but have greater demand for individualized, AI-driven health insights for personalized and timely care. And I believe none of you will disagree that health for us starts the very moment we are born. And that is the importance of keeping well. We can apply AI to our daily activities to derive health insights. Apps that take photos of your meal and calculate calories and nutritional values. Smart wearables that track and analyze our activity levels and sleep quality, with summarized statistics that are easily understood by residents to walk into changes in lifestyle, such as nudging residents to walk when they've been sitting for too long. Smart vital signs monitoring using devices that are capable of uploading into a central health repository with analytics and insights back to the resident, giving them personalized advice, such as having too many high blood pressure readings, prompting the resident to consult a doctor with regards to possible hypertension. And all this information to be tracked as part of personal health records, so that every resident is empowered to make personal plans, track their own health, find out about the symptoms of the disease, be able to search a trusted health library, and be linked up with relevant health providers. Health chatbots and insights can also give individualized advice based on submitted info. But beyond primary prevention, when chronic diseases have set in, patients can be engaged to get well and focus on secondary prevention. And SingHealth is enhancing our patients' future outpatient journey. No longer will the patient have to wait till the consultation to see the doctor and get the information. This information can be front-loaded and sent to the patients, including questionnaires, to better prepare the patient ahead of time. Appointment making can be via the app instead of a registration counter. And after seeing the doctor, they no longer have to wait until the next visit to see the results. These results can be made available on Health Hub. Medications can be couriered to the patient instead of queuing at the pharmacy. Feedback can be given online. And in between visits, the app can be a virtual concierge and source of communication between the patients and the healthcare provider without a physical visit if not necessary. And beyond physical visits, can the patient adopt teleconsultation if his chronic disease and control are stable? With vital signs monitoring uploading, use of intelligent chatbots, I believe we can adopt more teleconsultation and make healthcare delivery smarter and more virtualized. A very similar preemptive downloading of timely, relevant, customized clinical and financial information to a patient before an operation or elective procedure can happen as well, so that our patients can have more time to absorb the information before the visit, and the doctor can devote more time to dive deeper into patient-specific questions instead of generic procedure information. Patients, and more so concerned family members and caregivers, are usually very distressed during unplanned visits and admissions. They often are at a loss as to what has happened and how things will move from there. Through engagement via apps as an alternative way, they can then receive timely updates about the disease, severity, progression, estimated length of stay, the moment the healthcare provider enters this information in our national health records. And as for the healthcare team, we can choose which relevant results with interpretations to be sent to the patients and the caregivers from the EMR via the app, and also provide timely updates on planned discharges as well as what to prepare for the journey home. Of course, this cannot and should not replace the doctor-patient relationship, but serve as an additional layer of timely updates, especially given that we have more patients in the foreseeable future and less healthcare professionals. If the patient still needs subacute care or has lost function and unable to return home, referrals to community hospitals can be made more insightful and purposeful. A web-based solution on browsers with prioritization algorithm which uses bed availability, patient's preference in locality, and likelihood of acceptance can aid the referral in choosing a more suitable community hospital. If patient still does not fulfill criteria of referral, the wizard can prompt the user on required actions, and the users can be alerted via SMS or even on the mobile app. In SingHealth Community Hospital, we emphasize a lot on patient-centered care. Once admitted, the patient can use the app to register individual care preferences and advanced care plans, which can better guide the healthcare team to work with the patient on co-creating personalized care plans. And these preferences can be uploaded into a common system so that the patient does not need to repeat this at every admission. This app can also have a further outreach to caregivers and family members, updating them on the patient status along the way from the multidisciplinary team. Family conferences can also be virtualized as well to save traveling time, given that every caregiver is part-time caregiver and also a part-time worker. And in this current context of restricted visitor numbers and COVID infection, to significantly lower the risk of such infection. There will be patients who develop complications, and that is when we need to focus on the quality of life and the social aspects of their well-being. It is all about living in the community as long as possible. In SingHealth Community Hospital, we believe in social prescribing, and the conventional way is to engage them on-site with various activities and encourage their stickiness after discharge with similar activities in the community. However, with the advent of mobile devices, such patients can be digitally enabled to participate in digital social prescribing and have access to not just the conventional network, but an extended and vibrant digital social prescribing network as well, opening up new avenues for podcasts, virtual tours, and many other online content that engages them not just physically, but mentally and emotionally as well. And such a formation of a virtual social prescribing community may serve as a support and networking group for this group of patients. While at home, chatbots can provide additional help in independent or assisted living through targeted linkages up with relevant community partners and services that help them to continue to live well in the community. This device app can also allow caregivers to track the patient's location, which is useful for patients with dementia. And I just want to end with this, that truly, there are no boundaries or borders in the digital age. We are only limited by our imagination and degree of digital literacy. With that, I thank you for your time. Thank you.
Thank you so much, Luke, for giving us a peek into the future of preventive healthcare. Now let's welcome Dr. Andrew Jones from AWS to the stage, where he'll be sharing how the cloud has made a difference for healthcare frontliners all around the world. Dr. Andrew, please.
Thank you very much, and pleasure to join you all today. As we move increasingly clinical data into the digital form, and we put more and more clinical solutions and rely upon more and more digital clinical solutions, we think there's some critical requirements for these solutions. And I just wanted to go through a couple of those today. Resilience, high availability is so important as we become reliant on clinical digital solutions. The way in which AWS tries to help customers and partners improve the resilience and availability of their clinical applications is through our global infrastructure. Now, what you can see here are all the regions of AWS's global infrastructure. Now, a region is a geographically distinct location. And if we have a look if we zoom in on Asia Pacific here, you can see all of the regions that we have in the area. Now, the red ones are ones which have been announced and will be live very shortly, and the blue ones are existing regions. Now, let me just zoom in on the Singapore region. Now, the way in which our regions are arranged is in something we call availability zones. And Singapore region has 3 availability zones. And within these availability zones, there are numerous data centers. Now, what this allows us to be able to help customers do is create highly available applications. And what happens is that we can help customers develop applications which exist in more than one availability zone, something we call multi-AZ architectures. Now, these aren't the exact locations of the availability zones. We never disclose where our data centers are, but this is just to illustrate how that multi-AZ architecture can work. So if you develop a clinical application running in all these availability zones, a doctor within a hospital might be being served that application from one of those availability zones. Now, if that software or the infrastructure has any issue whatsoever, the multi-AZ architecture allows the continuing availability of that application by delivering it from another availability zone. This means you can have highly resilient and highly available clinical solutions running in the cloud. The second issue, the second critical requirement of healthcare applications is obviously security. And AWS provides very many layers of security to protect both the clinical systems running in AWS and also the data therein. Let me just go through some of those layers. Firstly, there's identity and access management. So this is about controlling who has access to the services and the data within the account, and that is only accessible to that customer. So no customer data is available to AWS. It's all under the control of the customer. And this identity and access management allows you to easily manage thousands of potential users and finally control what access they have. It also allows things like single sign-on, and also allows end users to maybe even use things like their Facebook ID or their Google ID or their Amazon ID in order to access services. The second layer is detection, and this is all about detecting possible threats to the security of the application. And so we have solutions and services which look for the configuration, the security configuration across a very wide range of services to look and ensure that that security is consistent throughout, and will also detect potential threats and attempts to breach that security. Then there's infrastructure protection, and this is all about reducing the threat of cyber attack. And so things like distributed denial of service or hacking of web applications, we have services which will protect end user applications from that. And then we have data protection services, and these enable customers to encrypt their data at rest and in transit. It also allows the identification of potentially personal identifiable information within the customer's data and put it into a more secure environment. And then finally, instant response. So if something does happen, it's all about responding to that incident. And as well as having services which help that, we also support customers in preparing for that. So those are the layers of security. The third critical requirement, I think, and we've seen it in the last 12 to 17 months, is the speed and agility of innovation within healthcare applications. Now, we talk a lot at AWS about the breadth and depth of our services, and I'm just going to cover them very briefly here. So we have compute, so virtual servers. We have storage services, a very wide range of databases, but also we have things like AI and machine learning services, analytics, development tools, business applications, mobility, IoT, app integration, ways of managing that, and networking, and of course, as I've just described, security. But what does this really mean? Well, this really means that all of these tools and services are available to rapidly develop innovative applications. And just to give you a few examples, so this is a Fire server created on AWS. We call it Fireworks, and this is created using those services. And any customer can use Fireworks and build it within an AWS environment in order to manage Fire messages. Let me go to another one. So this next one is actually a graph database with intelligent search. So this can ingest clinical information, put it in a graph database, which identifies the relationships between that data, and then uses natural language search in order to search for that. Third, another example here is one we established over the beginning of the pandemic. We were asked to help deliver PCR tests to people's homes, and what we required was both the logistics of Amazon, but also a digital platform upon which healthcare workers or the members of the general public could request a test and have that delivered to their homes. And this was established within 5 days. And obviously architectures can get very complex, but the existence of all of these services and the ability to bring them together really rapidly and in a really agile way allows organizations to develop new applications, to develop either with a pandemic or traditional healthcare issues really quickly and with great agility. So just a couple of examples. Cerner have built their population health management platform on AWS called Healthy Intent. And Cerner have had some amazing results developing algorithms which are capable of predicting, for example, heart failure, the risk of someone deteriorating with heart failure. Now, as clinicians, we often, the first we know of a patient who is deteriorated rapidly because of heart failure is on the day, 5 a.m. in the morning quite frequently. But Cerner were able to develop an algorithm which was able to predict this decline 12 months ahead of the actual incident. Now, that gives a lot of time to allow clinicians to intervene and prevent that from happening. Another example over the pandemic was PanSurge. Now, this was a group created by Imperial College, and they really were struggling to manage all of the clinical evidence coming out relating to COVID-19. At the time, there were about 200,000 articles. Now there's about 500,000 articles. And they created a data lake with all of that information within with all of that research data. And it allowed clinicians to ask simple natural language questions such as, do I perform an appendectomy on this patient with appendicitis who is COVID-19 positive, for example? And two other examples. OTN is a telehealth network in Ontario in Canada. Now they deliver telehealth services. They saw an increase of 4,000% in the use of their telehealth services at the beginning of the pandemic. And because they were built on AWS, it meant that they could accommodate that massive growth in demand and we're able to deal with that. And then Blue Dot, finally. Blue Dot was an organization actually set up during the SARS pandemic. And what Blue Dot does, it seeks lots of information about emerging infectious diseases, new and known, across the world, and helps to predict their impact. And I can talk a little bit more about that later. But I hope that was a good summary for you, and I look forward to the panel discussion.
Thank you so much, Dr. Andrew, for taking us on that mini world tour with your sharing. So we'll now be moving on to something I'm sure we've all been waiting for, the panel discussion. So today we'll be using the 3 Horizons model to guide our discussion on the move towards integrated healthcare. And you'll see that on your screen as we go along. This is a model pioneered by the Lee Kuan Yew School of Public Policy, and is a useful way to structure our thinking around how to address future challenges and how to move forward. If you have any questions, be sure to type them in the chat, and remember to tell us who you would like to direct your question to. All right, so let's bring up our panelists and dive right in. Let's start off by laying the ground a little bit. We can't really talk about healthcare today without talking about COVID-19. So Andy, if I could bring my first question to you, how has COVID-19 shown the need for personalized and integrated healthcare services?
Hi, thanks for the question. I think for COVID-19, it has resulted in an unprecedented search for hospital care, as well as pushing our healthcare systems to the edge. There are 2 key issues here. Our frontline workers are exhausted, but they need to respond faster, while they need additional information for consideration due to the different complex situation happening on the ground. To do this, we have actually taken data from the different systems to develop an AI-powered risk assessment tool to help in decision support that's intended to reduce admission for patients with mild pneumonia and prioritizing patients with life-threatening pneumonia cases to be received with critical care timely. Now, this is something that we have done not just to respond to COVID, but to make sure that it is a solution that will help patients beyond the COVID pandemic. In addition to doing that, we are also trying to make sure that we provide our healthcare workers with the right information timely to help them make decisions faster so that care can be efficient and care can be as good as possible even during this difficult time. The other issue that what we have is that we have a skills or experience gap because we have many non-clinically trained personnel being deployed to lean forward to support COVID operations. To do this, what we have to do is to make sure that we bring data in a way that is simple and derived so that laymen or even people with some clinical training can actually benefit from this data to support them in their daily operations. with MOH, we have done this by creating a COVID test repository that automatically collects and collates data from all the labs within Singapore, private or public, and clean, harmonize, and translate the data so that it can be used on the ground efficiently. So these are some of the ways that we have integrated data to help. In addition, at the hospital level, where I think Dr. Jamie Lim can actually talk about more, is the C3 systems that we stepped up to respond to the emerging situation, where we have built a system from a technical perspective to be able to sense with integrated data across the hospital to orientate and coordinate the resources at scale. It has the foresight using AI predictions to identify any potential situations ahead of time, as well as to optimize through simulation models of different options to decide on the best solution to be implemented on the ground. We hope that this can help not just for our patients, but for our frontline workers to ensure that they are supported with the best tools and data so that they can make their best decisions to help our patients.
Fantastic. Thank you for giving IHiS's perspective on that, Andy. And Dr. Andrew, I'm going to bring my next question to you. So what sort of impact has disparate data sources had on healthcare organizations around the world in the past year?
Yeah, I think we've seen both the challenges and the opportunities of these disparate and siloed data sources. I mean, I think there have been some amazing examples of the power in bringing these together. I mean, we saw some health systems realize the absence of consolidated and aggregated data sources really impair their ability to rapidly plan changes to health services in the face of the pandemic, or even know where resources were or what the demands might be. And in some cases, vital data wasn't even being captured in a digital form. I mean, lots of these organizations reacted really rapidly out of necessity and installed platforms where they didn't exist in the cloud to collect and aggregate this data. I mean, and now they're really able to understand the utilization of their assets and their workforce and anticipate future demand and the need for these resources. The rapid adoption of cloud, incredibly quick development of new capabilities in the cloud has meant that, the world, I think, is much better prepared than it ever has been before. I mean, in my talk, I mentioned Blue Dot as well, and just a bit more information on that. I mean, Blue Dot was a platform built on AWS, and it brings together all sorts of data sources. These include reports of novel infectious disease from public health bodies and governments, but also social media feeds where early reports were often, discussed between experts of possible new viral outbreaks. And Blue Dot are able to extract all of that information using natural language. They then combine it with non-healthcare data as well, things like airline flights globally. And using that, they were able to predict with quite high accuracy the 20 cities outside of China who were most likely to be impacted by COVID-19. AWS also helps people share anonymized and aggregated data sets using Amazon Data Exchange. And we had, one of the largest data sets of COVID-19 related research called CORD-19 on that service. PanSurge, I mentioned PanSurge, and it was such a good example of solving a problem right in front of you. The challenge was how do we analyze all this evidence around how to treat patients, and pulling all of those 500,000 research articles and allowing clinicians to answer clinical questions at the point of care was really important. So I think it's been really mixed. I think some people were ahead of the game, and I think those who weren't at the time have caught up really quickly by building some amazing cloud-based applications on AWS to solve some of those problems.
Absolutely. And while we're talking about data, Chris, what are some of the key data concerns as we look to creating integrated and personalized healthcare?
Well, yeah, ask me this question, right? I'm the only doom and gloom bringer in the room. So I think one of the challenges and the future looks actually pretty bright. So we talked about a lot about integrated care and bringing care from the acute hospitals to the community, and these are all very good approaches and good initiatives. One of the challenges that I see as I work in the data governance and data protection space is that sometimes this is at odds with what we want to do in terms of data security. So those of us who are in public healthcare know that over the last 2 years, because of a massive cyber incident, one of our approaches towards data security is to build higher and thicker walls around the systems in hospitals, and not just that, but in systems like NEHR as well. But on a flip side, you want to make such services and systems of records and systems of engagement available to the wider community. So then how then do you balance that greater access with greater security? Something that's probably going to be both a technical and a governance challenge over the next few years in how we want to do this. And actually, I wanted to help answer some of the questions that also popped up. I think Zui asked who should be in charge of analyzing, tracking, and advising on health behaviors. And this really speaks to where people think the data should flow. And the natural thinking is that is it either the acute hospitals or is it a government agency? But I think these days we can see that globally, people want to have the right to choose who gets to advise them on their behaviors, get to choose what's the right care plan for themselves among their various options. And a lot of that requires then data portability. And that also means taking health data out from highly protected, secure environments and distributing them more widely. And I don't have an answer for that right now, but that's probably one of the challenges that we'll need to tackle together as a healthcare community and as a health community, because it's not just going to be acute hospitals, is not just the primary care networks, but it's also going to be technology partners like AWS, is going to be wellness partners like Fitbit, like your various systems, commercial partners, and all these players have to integrate better for better healthcare, better health in Singapore. And I don't know whether we've managed, again, I only can bring problems. I'm not going to come with the usual admonitions, please protect your data, but we do see the opportunities and the challenges in front, and then how then do we balance between the two and create a good path forward? I think that's going to be one of the challenges over the next few years that we need to tackle.
Thank you for that, Chris. And now that we've laid out some of the key issues that we're grappling with, let's move on to discuss what's the hopeful future. Dr. Simon, if I could turn to you, what would fully integrated and personalized healthcare look like for patients and polyclinics? So what are some of the possibilities there?
I think it has to do with how does the patient journey look like, and that involve all parties in view of the patient. I start with the patient first of all, and that's how I try to lead up to the patient must have information on its own health condition, data at his fingertips, his results, his appointments, where are they due, what diagnosis does he have. If I'm asking what medication he should know what medication he should take. He should keep track of his vital signs, his blood pressure, his weight. I think Prof mentioned about the trackers, for example. So again, you can keep track of his steps all in one app if possible, instead of having a HPV app for steps, another one for Lumi Health, another one here and there. So it should be all in one place, and that will actually. And I think there was a question about whether can we integrate Health Hub with Health Buddy, for example. I think all of us trying to merge into one so that our patients have a single port of call for all this information. So that's for the patient itself. And then I was trying to allude earlier about horizontal and vertical. So all those within the health the community of care providers for this patient should be able to access the information with subject to the bounds of data sharing and what's appropriate, so that they have a holistic picture of how the patient is, what needs to be done for this patient. And when I say information, I don't just refer to medical information. It can also refer to things like the patient social needs. This goes beyond just public healthcare. It also goes to community partners, social partners. Some patients may not require people to intervene, but some may require people to reach out to them and help them, for example, if they miss appointments and all that. But ultimately, I think we envisage a patient journey to be quite seamless, and patient should be, in the ideal world, the patient should be able to seek care and draw care for wherever he or she needs it. Over.
Fantastic. Thank you, Dr. Simon. I think we're all looking forward to having that one app to take care of all our healthcare needs. So, Dr. Jamie, I'm going to turn to you next. So, Andy mentioned the C3 system earlier. Can you tell us a bit more about how data analytics and AI are already being used to fight COVID-19?
Okay, I will start off by saying that data is the new currency. And with data comes power, and with power comes responsibility. And I think the biggest challenge in healthcare is that data resides at different settings. And the ability to pull the data together, to make use of data and translate that into meaningful information is critical in order to deliver good, seamless care to the patient. So where I'm coming from an ops perspective, is that in order to deliver integrated care for the patient, we need to be able to marry both clinical data and operational data. So Simon talked a lot about the NG-EMR, which is the next big thing that's going to help to string together the pieces. But behind the NG-EMR is actually the processes that we need to get them well-oiled so that we are able to flow the patients from one setting to the other setting. So you mentioned about C3. So C3 is a command center that we are talking about. It is a system of systems which pulls together different set of data from different IT systems. And what it does is it provides a more holistic picture of the entire system. You have to understand that in a healthcare system, it is not just the tertiary hospital. There are different partners in this ecosystem. So we have the primary care partners like the Polyclinics, we have the tertiary hospital, we have the step-down care, community partners, nursing homes, and of course we have the ministry as well who comes in. And the ability to string the data, to make sense of it across the different settings, help us to allow the patient to transit seamlessly to right-side the care for these patients. So the C3 system allows us this bird's eye view. I would use the analogy of an airport control tower. And the airport control tower, basically the airport controller, manages the landing and the takeoff of the aircraft. And the flight controller also knows which aircraft is on land, right, and preparing to take off next. So the C3 system acts as a command center to allow us to maneuver the different resources so that we can better manage care, better allocate where the resources are most needed to deliver those care. And I think that's very pertinent during the COVID outbreak last year, where we needed to pool resources, especially in the Novena campus, where we support the National Center for Infectious Diseases. And we needed to pool doctors, equipment, and even nurses to NCID in order to support the COVID outbreak. And that would mean trying to down some of the services in the main Tan Tock Seng hospital so that we could move the manpower across the road to the next building. So the C3 command center provides us that bird's eye view of the entire system and therefore allows us to optimize the resources.
Thanks very much, Dr. Jamie. And I'm sure we've seen how C3 has been very, very crucial to Singapore's fight against COVID as well. And right now, we're going to look at what is worth keeping from the present. So, Luke, SingHealth has such a diverse group of healthcare organizations under its wing. And what are some of the lessons that you've gathered on creating a more seamless experience for patients?
Yeah, thanks, Annabelle. Yeah, actually in SingHealth, we do not just focus on the healthcare indices of the patient, but we really also pay close attention to the experience of our patient as well. So that being said, how to make it more seamless. And with increasing complexity of our patients, as well as the healthcare system, there are increasingly more and more touch points as the patients can move between acute hospitals, community hospitals, polyclinics, GP clinics, and also our VWO community partners. Really, the greatest risk to the patients is when they transfer and transit across care spectrum and there is poor handover. And such patient then falls through the cracks and suffer a bad experience in care transfer. Well, between acute hospitals and community hospitals in SingHealth, we have our own internal referral system that ensures that the pertinent clinical information is visible to each other and there is no loss of such critical information between the hospitals. Even as the patients are discharged from the hospital to the community, we have various services like the hospital to home program, as well as our community nurses to help ensure that the complex and frail patients are transited back home and to primary care as seamless as possible. But the clinical systems that are used by our nurses in the community is the same as what we have in the rest of SingHealth to ensure that our nurses have access to the same information as in the hospital. And the same goes for our polyclinics. And that is why they are able to continue chronic care for our patients after they've been discharged from the acute hospitals. Going down to the level of the GP clinics and family physician clinics in the Southeast, East, and northeast part of Singapore. And we have really encouraged them to come together to form primary care networks and develop care processes, transitions, and handovers for patients who choose to see their own family doctor. Of course, we are really still some ways from the ideal state, but I see it as that we have come such a long way in linking and integrating our various systems together as a regional health system. And we can only get better and better at this. And also just to answer about how we can allow the patient himself to share the data at their convenience across public and private sectors while ensuring that the data remains secure. I see the ideal state as each and every patient holding on to his or her digital health passport. When this patient goes to the polyclinic, he gets the option to share his information with this particular polyclinic that is seeing across cluster. And of course, if he even goes to a GP clinic, he can then select the GP clinic's name, and the relevant information is then shared with the GP clinic. And the patient can choose what to share and what not to share. Of course, the more sharing information, the better, because that simply enables the healthcare provider to do more for the patient with more information. But certain information, what we call the sensitive health information, like if the patient has certain psychiatric diagnosis that he does not want to divulge to the doctor, he also can choose not to share certain information, but then he has to understand the implications of care that may not be as optimal as it should be. So really, the personalized digital health passport, I feel, is one of the greatest improvement we can ever look forward to for seamless experience. Thank you.
Absolutely. And Andy, from your perspective, what are some of the next steps that the healthcare community can take to move towards integrated services?
Oh, that's a very big statement, but I think what we can do is to really invest on the infrastructure and the data sharing platforms, which can allow for data to flow into different hands where people can actually apply their domain expertise to use them. Now, I think a lot of times we blame it on disparate data sources, but I look at it that databases are actually created for particular purposes, which is to support transaction. And it is not possible to create one mega database to support that, right? Therefore, disparate database is a fact, as a practical thing, as well as it's an issue that we have to grapple with and then to make sense of it. But what we can focus on is to build and lay secure and reliable pipes to a secure and reliable database that can collect this data for analytical use. Have a group of people who can engineer, clean, harmonize the data to make it usable so that we can put it in the hands of analysts to allow them to experiment and try out different tools to see how we can improve the health of our patients or individuals with different data points, as well as collaborate with others. I think that's the most important part in the next few years for Singapore.
Thank you for that. And Chris, I know earlier you said that there are no easy solutions to the data problem at all, but if you were to take a stab at it, what would you suggest healthcare organizations do?
Well, I think that from a certain perspective, we have two sets of problems in the data governance and data protection sphere. One is, of course, the technical sets of issues, which I think Andy will be very familiar with. How do we secure environments, ensure that have good identity management, access management, and so on and so forth, and hardening of your firewalls and everything. I mean, all those are the technical measures which I think it's a known issue of how we want to do it, and a lot of it's just differentiating between the cost and the utility of and security considerations. I think one thing which we pay less attention to, but we should do more of, is a lot about user education, both not in just securing data and ensuring that data is used for the correct purposes, but also thinking of how then whatever data that a department or hospital or clinic collects can be contributed meaningfully to a larger database, whether it's for research, whether it's for operational improvements, whether it's for public health programs, and so on and so forth. So it's always trying to have this balancing tool between securing the data, which is important, and many of the people asking questions talk about it, but also making the data available, because many of the bright futures that my colleagues have pointed out are not possible if everyone thinks that if I share the data and it gets lost, then I have to appear in court or I have to answer for a data breach. So that's when where without the trust factor, without an incentive or a desire to share more data, then a lot of these systems then don't happen. So one of the things that I would say that in order to move forward better, I think a lot of the governance issues about user education, trying to encourage and to first, a lot of it is about people, right? So firstly, the actors in the space currently have to understand what their obligations are and how they can protect data, what are the opportunities that they can have in using data safely, and that will support a lot of the analytics and operations work. And also then think about who else in the ecosystem and how do you expand that ecosystem so that more people can come in and make use of the data. So one of the challenges, I guess, in the healthcare space is always, we think that health data is best used by clinicians in a certain respect. And we do know that at least in the tech world, a lot of the faster movers in terms of public health and all that happen in the non-clinician space. A lot of these are going to be like technology companies and so on and so forth. That are supported by professionals, of course, but it's not directly a hospital healthcare environment. And then how then do you expand the ecosystem to incorporate them, and doing so in a safe manner that protects the privacy of patients as well as the security of the hospital's own data systems? I think that's one of the things that we can start to think about in order to make this bright future happen.
Absolutely. And Dr. Andrew, if you have any thoughts on where we can go from here.
Yeah, I mean, my thanks, I mean, to the rest of the panelists as well. Thank you so much for inviting me. I'm afraid I have to dash just after this. But I mean, I suppose in closing, I'd say, look, over the last 17 months, we've seen an astonishing rise in the adoption of new and existing healthcare applications, often in the cloud. And new healthcare applications being built on AWS within days and weeks, taking disparate data sources, connecting them, analyzing them. Existing applications such as telehealth solutions have been really scaled up, incredibly rapidly to meet the needs of the world population. And I think we've also seen a clearer focus on the immediate channels, the immediate challenges, and working backwards from that to design the right technology solutions. There's been more experimentation with novel solutions. It's happened at a faster rate. And there's been an acknowledgement that connected solutions are better solutions. And I believe that this new optimism for an experience of digital health solutions solving many of these issues as the world's faced its most challenging health crisis will transform into long-term trust in the ability of health technology to solve the global challenges of healthcare.
Fantastic. Thank you so much, Dr. Andrew. And thank you everyone for joining us this afternoon. Thank you to our panelists and to our wonderful audience. We have heard from an amazing panel of speakers today on how we can move forward towards a more integrated, intuitive, and personalized healthcare system. Dr. Jamie mentioned earlier that the biggest healthcare challenge that everyone's facing is that data sits in different places, and we've seen how the C3 Command Center has addressed that. So moving forward, could other healthcare clusters have its own C3? And thank you so much for tuning in today. We hope that you have learned something new and are excited about the opportunities on the horizon. If you have any questions or would like to know more, please feel free to get in touch with the GovInsider or the AWS team. Until the next time, goodbye.